Welcome to the September webinar on GDNF therapy, gene therapy. Thank you to our presenter today, Dr. Nisha Chhabria, who works for AskBio. She and Dr. Amber Van Laar are colleagues and friends, and she's going to talk all about gene therapy today. And thank you for joining. I will do a brief introduction. Dr. Chhabria is a fellowship-trained movement disorder specialist prior to joining AskBio. And she was an investigator in over 90 clinical trials dedicated to Parkinson's disease and movement disorders. She is now a medical director for clinical development for the GDNF program and the project lead for Regenerate PD, AskBio's gene therapy trial for Parkinson's disease. Thank you for taking the time for Parkinson's Foundation, Western Pennsylvania. Please take it away, Dr. Chhabria.
Thank you so much for inviting me. I'm honored to be able to present to you guys today, and I hope you have a better understanding of what we're working on at AskBio after this presentation. So let me share my screen with you guys. Let's get this into presentation mode. All right. So as Casey said, my name is Dr. Nisha Chhabria, and I am the medical director for clinical development on our CNS team. And today we're going to do an overview of GDNF therapy for gene therapy for Parkinson's disease. So these are my disclosures. So these are our topics that we're going to discuss today. A lot of this stuff you guys might already know because I know my Parkinson's patients were very well educated on PD. So we can kind of go over some of this a little quickly. Okay, so as we know that Parkinson's disease is going to be what we consider to be an epidemic by 2050. It's increasing in frequency as our patient population is getting older. And so this is something that is definitely going to need better treatments, better management in the future. And as you guys know, as you take your levodopa, over time, the window for its therapeutic benefit gets smaller and smaller and smaller to the point where you start needing to take medication more frequently. You may have periods where you feel like your medicine isn't working, and your periods of where it is working get shorter and shorter. And you may also start developing those wiggly movements like Michael J. Fox experienced called dyskinesias. And despite the fact that we've done a lot to try to change the way we deliver levodopa, or with new therapies like pumps and infusion therapies, as well as longer acting levodopa, and then using other medications that help maybe enhance the effects of levodopa, and then also DBS, we just really don't have anything that can possibly help slow down the progression of this disease. So what has taken gene therapy so long? What are the challenges for the central nervous system? So really, it's where is the area of the brain that we need to go into? Why have we not figured that out yet? And that's what we're working on here at AskBio. And what is the right stage for Parkinson's? So it's hard to define mild, moderate, advanced, but we are trying to do that at AskBio to determine what's the right type of patient that we're looking for to treat with gene therapy. So our current treatment options for patients with Parkinson's, they just don't really address the underlying neurodegeneration. And we believe that gene therapy may offer a longer duration with only one administration. And we also feel that gene therapy may allow for neuroprotection and neurorestoration, which is huge in this disease process. So what is gene therapy? So let's start with what are genes. Genes are segments of our DNA, and they carry our genetic information. We all have 2 copies of each gene, and we get them from our parents, one from each parent. And the Human Genome Project estimates that humans have about 20,000 to 25,000 genes, and there's less than 1% variability between individuals. So that less than 1% is what makes us who we are. So what are genes? Genes are your DNA, and these are instructions. Our cells read these genes or instructions, and they make new proteins. And then the proteins are used by the cells to signal health used by the cells to be able to basically make medicines essentially for your body. And that's basically what we're trying to do at AskBio. So our specific gene therapy, which is called AB1005 or AAV2 GDNF, uses what's called a viral vector. And so the AAV2 is our vector. And this is a dead capsid or virus, basically. So there's nothing in it that can get you sick. And then we use a transgene called GDNF, and that is the gene that's put inside the vector and then delivered to the brain to be able to get the brain cells to read this gene to make the GDNF, which is the protein that helps our cells grow back dying dopamine cells. So to put this more simply, the GDNF or the gene is a letter, and the virus, which like I said is empty, which is the capsid, that is our envelope. So what we do is we put the letter inside the envelope. So we put the gene inside the capsid, and then we basically package that together. And then through a surgical technique or using a delivery truck, we deliver that to the brain. And that's done one time. And then once it's delivered, the cells of our brain read this letter. So they unpackage the capsid, take out the gene, and then they read the gene. And then that gene then becomes the proteins that become the proteins needed to bring back dying dopamine cells. So I'm going to play you a little video that kind of shows you exactly what I just said. So that's, as you can see here, this is the gene. And then this is the vector. And then they go together inside one another. The gene goes inside the vector. And then that is then put into the brain, and the cells then read the gene. And then after it's reading the gene, it then sends out the GDNF. As you can see, those little green dots that are going everywhere to all the other cells. So why do we want to do gene therapy for Parkinson's disease? Well, as we've said, as I've been saying over and over, our medications are effective. However, they lose their efficacy over time, and you start needing to take medication more and more frequently. And this is not specific to a specific genetic disease. And as we know, in Parkinson's disease, about 10 to 15% of Parkinson's is from a genetic mutation like GBA or LRRK2, but that's not what we're doing. We're not working specifically on those types of forms of Parkinson's disease. And this is a one-time treatment. So this is a one and done treatment. And we've been looking at GDNF for years and years and years and using different delivery techniques to be able to get the GDNF into the body. The problem is we've realized that the delivery of GDNF is what is the reason for why it hasn't worked effectively in all the studies that have been done over the last 20, 30 years. And we feel that the delivery of GDNF by using this viral vector seems to be a more effective way of getting GDNF to the brain. And GDNF, and I'm not sure if any of you have learned this before in the past, but this is something that we all make. We all make GDNF when we exercise. However, we don't make enough GDNF to be able to do what we can do with our therapy. So GDNF is basically, as one of my colleagues likes to say, is a CPR for dying dopamine cells. So we can't bring back the dead cells, but we can try to bring back the ones that are dying or sick. And trying to bring back that helps us make more dopamine. So eventually the goal would be to be able to lower the amount of dopamine that you would need to take in the form of levodopa. So how do we do this? How do we get it into the brain? So what we use is an MRI guided therapy. So we have the patient laying on a MRI table using a system called ClearPoint. And we use MRI guidance to be able to watch as we infuse as we go to deliver this therapy. And this is something that's been done for over 15 years. And like I said, this is a one-time procedure. So here's a nice little video of what we're trying to do. So the cannula is that very tiny rod that you see there. It's a hollow tube, and then as we move forward, we infuse the medication. Like I said, under MRI guidance. The patient is under general anesthesia during this procedure, and it's a one-time procedure. Of note, yes, this is a surgical procedure, but I would like to say that this is a less invasive procedure versus something like DBS, where the hole in the back of the brain is so tiny, it's actually the size of my pinky nail. And some surgeons have actually said they don't even need to close the hole once they're done. Most will use glue or one dissolvable suture just to make sure that it heals. But technically, they said that that's something they don't actually have to do. The other thing about this is you don't have to shave your head as you would for DBS. So unlike DBS, where you have the larger holes in your head and you have to shave your head and hardware is left behind, none of that is the case with this. So this is a video of how we actually do the infuse as you go process. So this is obviously done very quickly to show you, but this is a procedure that takes about 2 to 3 hours to actually complete. And what you see is the gadolinium that is added to the investigational product so that we can see in real time how we're covering what's called the putamen, which is our movement center of our brain, with the investigational product. And our goal is to get at least 50% of each putamen covered with AB1005. And really, like I said, there's no hardware, there's no maintenance. We don't have to do constant tweaking of the DBS to be able to get the symptom relief that we need. Patients stay in the hospital about a day or two, and then they go home, and then they're monitored very closely in our clinical trial. So let me show you some data regarding our current phase 1b study that's still ongoing. This data has been published in the Movement Disorder Journal and is readily available for anyone to review. So basically for that study, we looked at two different cohorts. We looked at a mild cohort and a moderate cohort, and there were 11 patients in that study. And we have actually completed now 48 months of this study with patients now entering into the 60-month period. For our cohorts, they had the same age, basically for the patient population, about 55 years old, mainly men. For the mild cohort, they had been diagnosed about 2 years, and for the moderate, about 7. For the MDSU PDRS Part 3 off, which is the assessment where the doctors have you tap your fingers and open and close your hands. That was about 20 for the mild and about 42 for the moderate, with a significant improvement once they took their medication. And the medication doses for these patients was about 500 for the mild and about 1,000 for the moderate. And like I said, you've seen this video, we were able to actually achieve about 63% coverage between the two cohorts, which is excellent and very different than previous techniques that have been used for this specific type of medication. From a side effect perspective, it's essentially what you would expect to see when you're laying on a table and having a surgical procedure. So headache secondary to having had the procedure, and then some muscle aches and fatigues because they're laying on the table for a period of time. And then post-operatively, we did see some dyskinesia, those writhing, twisting, jerking movements. And then this was done during COVID, so there were some COVID infections during the study. But here's the really impressive part, and this is why we're moving on to a phase 2, is in the mild cohort, we were able to see essentially stabilization from baseline to 18 months. The reason you see that slight little uptick in that red line in the mild cohort is one of those patients had a genetic mutation for something called tyrosine hydroxylase. And that mutation actually leads to worsening of something called dystonia, which is where the muscles contract and can be painful. when the patient turns off. And that's why you see that uptick in the red line. If we remove that one patient, everything would be straight lines across the board. And then for our moderate cohort, remember how I said that they started with a score of about 40, 42 in the screening baseline period? Well, we saw a dramatic improvement of almost 50% reduction in that red line, the off periods, to basically almost a 20 in their off period. So they essentially, if you look at this, went into what looks like the mild cohort after undergoing this treatment. And then we look at the PD motor diaries, which these diaries, they basically are something that you as a patient would fill out. They're every 30 minutes, you would mark if you're asleep, you would mark if your medicine is working, meaning you're on, you would mark if your medicine isn't working, meaning off, and then you would also mark if you may have an experience of dyskinesias, and whether they were troublesome or non-troublesome. So we're looking specifically here at our moderate cohort, and you can see that they had about 11 hours of on time and about 4 hours of off time. And then at 12 months, there actually was an improvement of about 3 hours in the good on time with a reduction of almost 2 hours in the off time. And that was definitely seen at 18 months. So that's a pretty dramatic improvement on patient-reported outcomes. So what does this mean? So basically, this was an open label study. So we do know that in Parkinson's studies, that there is a really large placebo effect. So something that can be ongoing in surgical studies for almost up to 18 months. And so we can't say that these results are truly because of our medication, because of that potential for placebo effect, but we can be encouraged by these numbers that I showed you. And because we did see such a improvement in that moderate group, that's what made us decide to target that moderate group for our upcoming or for our current phase 2 study. And as I said, we do have patients now entering 5 years into this study. So we are really looking forward to seeing that data as it comes through. So let me talk to you more about our phase 2 study. This is called Regenerate PD. It's a phase 2 randomized double-blind sham surgery controlled study of the efficacy and safety of intraputamental AB1005 treatment of adults with moderate stage Parkinson's disease. So this is a schema of how our study works. So we go through a screening period where patients are evaluated through multiple assessments. They then go into the baseline period where they go through even more assessments, and then they end up getting randomized in a 2-to-1 fashion. And randomization for us is surgery. And they get 2 patients to AB1005 and 1 patient to control. And as I said, this is a one-time procedure. They then are followed up every 3 to 6 months in a double-blind fashion where they undergo assessments, imaging, and just safety measures. And then once the last participant hits 18 months, we will unblind the study. And if we determine the study to be safe and effective, those that receive the control surgery will have the opportunity to undergo the surgery. And those that did receive the surgery will be asked to participate in a long-term follow-up for up to 5 years, if not longer. So what we're looking for this study is we're looking for adults between the ages of 45 to 75. They need to have been diagnosed with Parkinson's on paper within 4 to 10 years. They need to be experiencing off periods, and they need to be on medication that's been stable for at least 4 weeks prior to being screened, and they need to be responsive to levodopa. And then for an exclusion criteria, we're looking for specifically what we call idiopathic Parkinson's. So if you know that you have Parkinson's from, say, GBA or LRRK2, or maybe you've had repetitive head trauma, or any other cause that could be causing you to have Parkinson's disease, we would have to exclude you from this study. If you have a history of psychosis or severe depression, anxiety, or cognitive problems, we would have to exclude you. And if you've had a previous history of brain surgery. And of note, these are not all of our inclusion criteria. These are just some of our key inclusion-exclusion criteria. So in the United States, this is where this study is being done. Anything in blue would be our neurology sites. Anything in purple is a combination neurology neurosurgery site, and anything in red is just a surgical site. So for those of you who are in Pittsburgh, to be honest, I don't know if Detroit or Philadelphia would be closest for you, but those would probably be your closest options. We do provide a concierge service that actually provides travel for everything. So whether it be the neurological visits, whether it be for the surgery or for our imaging that has to be done at certain centers, we pay for all of that. We also pay for lodging, and we pay for a companion to go with you as well. How do you participate if you're interested in a clinical trial? So the first thing I would do is talk to your neurologist. See if they can teach you more about gene therapy to see if this is something that is right for you. And then they would be able to refer you to one of our surgical sites. Our neurological sites. You can also find us on the Fox Trial Finder. And then I'm going to keep this up for a little bit just in case anyone is interested in this study. The QR code that's on this page right here, this QR code takes you to a nurse navigating system called My Tomorrows. And essentially, the QR code goes to their landing page. You answer a bunch of questions, and a nurse will then contact you to review the inclusion exclusion criteria for our study. And if you don't qualify for our study, they put you on a list for other potential Parkinson's studies that you may be interested in participating in. So it's not just something that's dedicated to us at AskBio. It's a system that helps us get patients for our trial, but also potentially for other trials that are there. Other ways that you can find us, like I said, is the Fox Trial Finder. We are on clinicaltrials.gov. And you can also always send an email to askfirst@askbio.com. It is a live person who answers that email, and they can try to answer your questions. And then they also will refer you to My Tomorrows as well. And I'll come back to this slide after we're done and keep this up while I'm answering your questions. The question in the chat, is that something I need to answer right now?
You can wait.
And just, oh, sorry. Go ahead.
You can wait till the end.
Okay, I'm almost done.
Okay.
And then just a little bit about who we are. So AskBio is the leader in next generation AAV gene therapy and a pioneer in almost every element of design, application, and manufacturing of AAV therapeutics. We were founded in 2001 by Jude Samolsky, and we are literally working in pipelines of not just neurology, but neuromuscular, respiratory, and heart. We have 500 employees across the globe. And we've actually had our technology used by different companies such as Pfizer, Takeda, and Novartis. And so I just talked about this. This is Ask First. There are patient advocacy and engagement. And so we are also a subsidiary of Bayer. We were purchased by Bayer in 2020 to be a part of their cell and gene therapy platform. And we are a fully independent subsidiary of them. And again, ask first. And I'd like to say thank you for taking time to listen to me. I will go back to this slide and keep it up while I answer your questions in case anyone wants to use the My Tomorrows link. So fire away with your questions.
Now is your time to ask all about gene therapy. And it wasn't actually a chat, it was a mention, or excuse me, it wasn't a question. If you have family or friends in a specific location, you can request that procedures be done at a specific location.
100%. Yeah, actually, that was a question that we got from one of our PIs at one of our sites. The patient actually lives in New York, but sees the doctor in Las Vegas and wanted to know if they could have surgery closer to home. And the answer was yes, they can go to Boston for surgery. So yes, if you have family in any one of those locations, we encourage that to be the site that you would go to for your surgical procedure.
All right. Do you expect that if the trial is successful, that persons who have had DBS will not be able to benefit from this process?
So that's a good question. I know that we have discussed doing our procedure and then patients having DBS afterwards. And that's actually happened in our phase 1B study. We've actually had 2 patients who underwent our procedure and then 5 years later actually needed to undergo DBS. Um, but I'm not sure if the reverse is possible. And the reason I say that is because of where we're targeting. I think we may not be able to get to the putamen when there's wires in the way. So that would be the reason why I'd say possibly no. But that is a really good question, and that's something we definitely need to consider.
Thank you. Is a person disqualified if they have been treated for depression and anxiety?
No, if they're on stable treatment for depression and anxiety and are stable on these medications, meaning that their depression and anxiety is not out of control, then no, they do qualify. We do a lot of anxiety depression assessments for this study, and actually one of the assessments, it's called a BDI-2. It's the Beck Depression Scale, and that if you score over 20 on that, that is an exclusion factor on that. But if you are stable on your medications and you are doing well on those medicines, it's unlikely that you would score 20 on that scale.
Thank you.
Nisha, we have a person on this call who is in the process of doing all the pre-work and is scheduled for surgery in November. And I
Excellent.
reached out to her to see if she would be willing to chat about her experience, and I haven't heard back. But I just wanted to put that out there that if she has been very gracious in sharing her experience with the support group that she's in and providing a lot of comfort to people. So I just put that out there. I will find out if she is willing to chat to people individually or not, but we have some folks in the program.
That's fantastic. And that would be amazing if she'd be willing to share her experience and be able to let people know how strenuous of a study this can be. I'm just kidding.
Strenuous for you.
Yes, for me specifically, exactly. Yeah.
Here we go.
Is there a timeline for approval of this therapy? So many, many years from now. This is definitely something that's going to be coming in the pipeline for sure. I can't give you a specific time as to when this is going to happen. We are currently enrolling for our clinical trial, with the goal to be fully enrolled by the end of next be a deterrent.
Many people have heard me say this before, but there are Parkinson's trials all over the world going on. But we are in a unique position to know Dr. Van Laar and Dr. Chhabria and to trust them. You know, this is a trial that's being put on by folks who have been very good to our Western Pennsylvania community. And that gives me an additional level of comfort. Just passing that along.
Good to know. And we appreciate you guys too. So.
Any other questions? Like I said, I think this is a video that will be viewed quite a bit online after the fact. And we'll make sure that people are aware it's out there. We're getting a thank you, so it seems like people are satisfied with questions. I also want to point out to everyone that this Saturday is our walk at the Cheswick Shrine Center of Pittsburgh, and we are going to have Dr. Ray Dorsey there talking about his new book, The Parkinson's Plan, and every family will get one book for free, signed by Ray. So we encourage you to come to that. We're going to have good food, good music, and a beautiful day. So if you haven't signed up, no worries. You can just show up and attend. Anything else? Well, thank you, Nisha. A wonderful presentation, and we hope to find more folks from our region to participate in your trial.
Well, thank you so much, and thanks for everything you guys do. We appreciate you, and anything that we can do to help you in the future, please, of course, let us know. And Kara, I think, dropped off, but she will see you on Saturday, so
Exactly. I can't wait, Kara. Thanks, everyone.
thank you.